Hello friends, I'm Dr. Bharat Jagyasi and welcome to my class. Today we'll be talking about overdose of calcium channel blockers and beta blocker, that is management of the overdose of calcium channel blockers and beta blockers in ICU. So to talk about the same, allow me to share my slides with you. Give me a moment, please. Yeah. So as we decided, this class is about the ICU toxicology, and the topic we are going to cover is about the overdose of beta blocker and calcium channel blocker and its management. So I'm Dr. Bharat Jagyasi. I am Director of Critical Care Department, Kuklaban Hospital, Navi Mumbai. I'm also Examination Secretary elect of the Indian College of Critical Care Medicine, and I was past General Secretary of ICCM in the year 2024 and 2025. So when we talk about the beta blocker toxicity, we're talking about the recognition and management of the common cardiovascular drug which is being used. So we know the beta blockers antagonize beta adrenergic receptors, and amongst the most commonly used cardiovascular drugs, and propranolol is one of the earliest manufactured as early as 1973, and the reason it's being used as an antihypertensive uh, drug with the for the heart failure, which has a mortality benefit, also for the arrhythmia, especially the tachyarrhythmias, angina pectoris. It's also being used for the non-cardiovascular reasons like angina pectoris, anxiety, migraine prophylaxis, essential tremors, hyperthyroidism, and glaucoma. It's very important to classify and know the toxicokinetics of each and every drug we handle in the overdose or the toxicology. So when we look into the beta blockers, they are traditionally being classified as beta selective blocker. That is, they block only the beta 1 receptors, and the drugs which are known to cause this are metoprolol, atenolol, asmolol, bisoprolol. They preferentially block only the cardiac beta 1 receptors, and then non-selective, which block both the cardiac as well as the pulmonary receptors, and those are the propranolol, nodenolol, and the carvedilol. But it's very important to know in the drug overdose, specificity is lost in most of the cases. Also, we can classify it as the lipophilic or the lipophobic. The reason being is the lipophilic agents have a larger volume of distribution and a more profound CNS effect. So if the lipophilic drug like propranolol and metoprolol comes with the patient comes with overdose of these drugs, they will readily cross the blood-brain barrier and cause CNS manifestations like seizures or the delirium. In contrast to the lipophobic drugs like atenolol and nadolol, where they undergo renal excretion and may cause fatigue. Also, there are certain membrane stabilizing drugs. By definition, we'll call them as a sodium channel blocking drugs, which are propranolol and acetoprolol. So the patient comes with those. Then we have many conduction disorders, ECG effects like QRS prolongation, and similar to the what we see in the tricyclic antidepressant. So it's very important to know the toxicokinetics of the drug, because then you would know how your patient is going to behave in certain cases, what drug he's taken. So when you talk of the etiology, why it happens, so usually it's of a clinical significance. It's influenced by the underlying psychiatric or the medical comorbidities, and it's more commonly seen in the female. Comparison is 3:1 as compared to the males, and the mean average age is around 30 years, and approximately two-thirds of the overdoses involve medication prescribed to another individual. So it's very important to know about the coexisting depression or the psychiatric condition, polypharmacies, whether they have taken along with any particular sedatives or other cardiovascular drugs like CCBs, which will eventually increase the risk and the mortality as well. And whether it was a medication error where we know just a small single one tablet has been taken, we don't look into the profound effects or the real morbidity coming in those situations. So as we discuss about, it's very important to know the history, importance of identifying co-ingestion, especially the anticholinergic and other cardiotoxic drugs, and the concomitant ingestion of CCB, which will cause profound hypotension, severe bradycardia, and increased cardiotoxicity, and also presence of underlying illnesses. It will further increase the risk of poor outcomes, disease like heart failure or the conduction abnormalities. And the different beta blockers we all understood have different half-lives, so which is crucial for predicting the duration, the severity of toxicity, guiding the management of the duration. So it's very important to know what time the drug was taken, estimated time, dose, and time of ingestion to predict the clinical course and the therapeutic needs. So when you look into the pathophysiology, that is metabolic and circulatory impact, it has the cardiovascular effect. It causes hypotension, bradycardia, especially the decreased assay nodal automaticity, decreased conductivity, that is negative inotropic effect on the myocardium, reduced oxygen consumption. It has also metabolic derangements like hypoglycemia, marked hypoglycemia symptoms like blunted, could be because of blunted catecholaminergic response. If those are non-selective drugs, they will also do the beta-2 blockage and will lead to the bronchospasm. So how do they present? So there's an early phase, progressive phase, and the severe toxicity. So early phase we see at somewhere around 0 to 2 hours, the patient presents with dizziness, fatigue, lightheadedness, bradycardia, and hypertension. Then we have the progressive phase where the worsening on the hemodynamic. We'll see little bit of hypertension coming in, altered mental status. If the drug is a lipophilic drug, then we might see the CNS depression as well, or maybe the seizures as it progresses to the severe toxicity when it's more than 6 hours, refractory shock, seizures, cardiovascular collapse, and eventually, if not treated and intervened appropriately, we might face pulses electrical activity. Then there are certain drugs which come with the extended release, like sotalol toxicity. The risk will go up to as high as to 20 hours. That is, it might present with the QTC prolongation, which will persist even for 3 to 4 days, especially in case of the sustained release preparation. Extended monitoring is required. So it's very important to know what kind of drug has been taken, estimated time and duration which has been taken. What you would do as in monitoring. So we do continuous cardiac monitoring with the 12-lead ECG. Of course, as we beta blockers causes hypoglycemia, is very important to measure the serum glucose as well. They also causes hypokalemia. So it's very important to the electrolyte monitoring. ECG is to be looking for sinus bradycardia, variable degree of AV blocks, bundle branch block, QRS widening, QT prolongation, and we might see the junctional rhythms as well. And it's very important to differentiate the beta blocker with the calcium channel blockers overdose because they mimic almost the same, but the major differentiating factor is in the beta blocker toxicity, we commonly see the hypoglycemia, but in case of the calcium channel toxicity, we might see the hyperglycemia. So glucose could be the one of the factor which will differentiate between the beta blocker overdose or the calcium channel blocker overdose. And also the altered mental status is seen with the beta blocker, but not really with the calcium channel blocker, unless and until the patient is having a profound hypertension or shock, then you would see the altered mental status even in the calcium channel blocker patients. So how do we manage these patients? So of course, as we talk about the ABC, the airway protection comes first, especially in the CNS lipophilic drugs, where we would see the CNS depression. We might have to intubate those patients. Always pre-medicate patient, especially the children with the atropine, to prevent the vagal mediated bradycardia during laryngoscopy. Then we will talk about the gastrointestinal decontamination, that is activated charcoal, which is to be administered within 1 to 2 hours. So it's more effective if administered within 1 hour, then beyond 3 to 4 hours, it has no effect. We can also consider the whole bowel irrigation, especially for the sustained release preparation, where it's quite useful. So initial resuscitation is, of course, with the crystalloid fluids for the hypertension, monitor for the fluid overload because there's a negative inotropic effect as well. And we can look for the specific antidotal therapy like glucagon, high dose insulin, euglycemia therapy, calcium salts, and vasopressors as we go forward. So when you talk about the decontamination, as we spoke, activated charcoal is very good when given within 1 hour, but it is not really helpful when given after 3 to 4 hours. And whole bowel irrigation with polyethylene glycol for sustained release preparation until the rectal effluent is clear ensures complete removal of unabsorbed medication. Then we can have the symptomatic specific management, especially if the patient presents with the seizures, and the benzodiazepines are the first line of treatment due to high lipophilicity of the certain beta blocker. Then we might look into the prolonged QRS, QTC prolongation, and those are to be so QRS widening could be treated with the sodium bicarbonate to stabilize myocardial sodium channels, and the QTC prolongation we might consider giving magnesium sulfate to mitigate risk of ventricular arrhythmias. Pharmacological intervention, the glucagon is the critical intervention for managing beta blockers because offering a mechanism that bypasses a typical beta adrenergic pathway. So we all know it increases intracellular cyclic EMP, leading to positive inotropic and chronotropic effects. So how do we use it? So initial bolus is of course 3 to 10 milligram, which is to be given over a period of 1 minute, and the effect is usually seen within 1 to 3 minutes, but the drug effect lasts only for 5 to 10 minutes. So it's very important to repeat the doses, or we might need a continuous infusion. So if the patient comes with severe doses, it might happen. So you will need a kind of glucagon which might not be available in whole of your state because the duration of action is very long. So we need a very good high doses of glucagon. And how do we know whether it's effective? Because it increases the heart rate, enhances myocardial contractility, and also alleviates blood pressure. Side effects, of course, we look for the hypocalcemia and the hyperglycemia. So I'll not go into the preparation and consideration. So when do we consider alternative therapy? Because if the glucagon is not effective, at that moment we consider high dose insulin euglycemia, and when the patient is not responsive to the fluid resuscitation as well. So insulin has also positive inotropic effect and can induce peripheral vasodilatation, improving tissue perfusion. So how do we do this? So it's almost the 3x or 10x of the dose of what we use in the diabetic ketoacidosis. So the initial bolus is somewhere around 1 unit per kilogram IV over 1 to 2 minutes, and we have to give it as a continuous infusion of 0.1 to 1 unit per kilogram per hour IV to titrate the effect depending on the blood pressure and the blood glucose what we are maintaining. Because we are giving very high dose of the insulin, we of course have to give the dextrose as well because we need to maintain glucose somewhere around 100 to 150 milligram per deciliter. So it's very important to check blood glucose every 15 to 30 minutes, and potassium as well, maybe hourly, to do high risk of profound hypokalemia. And we have to continuously monitor ECG in those situations. So major complication, what we're looking into is the profound hypokalemia and also the hypoglycemia. So it's very important to measure these two integrities when we are treating patient with high dose insulin euglycemia treatment. So as we understood, so it's very important to assess the pre-treatment requirement, that is the potassium level and the blood glucose level. The bolus doses, as I spoke about, 1 milligram, 1 unit per kilogram of insulin over 1 minute, followed by 0.5 gram, 0.5 followed by the infusion. And dextrose, how we give? So we give dextrose as a 0.5 gram per kilogram of 50% dextrose intravenously over 5 to 10 minutes. But it's very important to know, do not administer intravenous dextrose bolus to the patient glucose is more than 400. In such cases, proceed only with insulin bolus and initiate the maintenance insulin with dextrose as appropriate, that is closely monitoring the glucose levels. So beta blockers, we all understood the high dose insulin dosing differences. So how do we use it? So we have to use insulin at 1 unit per kilogram IV bolus, followed by the maintenance, and dextrose also, and sodium bicarbonate for the QRS prolongation, and magnesium for the QTC prolongation to mitigate the risk of the ventricular arrhythmia. In certain cases, we might have to do the transvenous pacing, especially when there's a profound bradycardia, or we might use the IBP for the refractory hypotension. Now, mechanical therapy where the fluid boluses are not acting, our glucagon is not enough, high insulin euglycemic treatment is not enough. Those are the areas where we might have to consider the ECMO, especially if there's a profound cardiac shock in spite of all the therapy and there's an impending cardiac arrest. So continuation of mechanical support will provide a temporary cardiorespiratory support, and it will allow the sufficient time for the xenobiotic effect or the beta blocker to wear off. It acts as a bridge therapy. And how do we enhance elimination techniques? So it's for the specific water soluble and the renally excreted beta blockers, there are effective methods that we can do the hemodialysis or the hemoperfusion. And also, as we spoke about the multiple charcoal activated therapy, but it is effective when we use within 1 to 3 hours. So it's very important to look how your patient is. There could be, if the dose is very small, the patient will respond to the initial just fluid therapy. Then the first line pharmacological therapy is a glucagon. If that is not effective, then the high dose insulin euglycemic therapy, followed by we might have to initiate the vasopressors. The first choice is a norepinephrine. If you need an inotropic effect, then we might have to use the dopamine or the dobutamine in certain cases as well. If nothing is working, then go for the transvenous pacing if there's a bradycardia. If there's a profound hypertension, then we might have to consider the VA ECMO in those cases. So, of course, severe poisoning, IV glucagon, IV calcium salt, vasopressors, high dose insulin and dextrose therapy. IV methylene blue can be used in certain vasoplegic cases and IV lipid emergent therapy as well. As I go forward, I'll explain about the IV lipid emergent therapy as well. But mild to moderate cases might do well just with the IV crystalloid, IV atropine or glucagon and vasopressor therapy. So now let's talk about the calcium channel blocker toxicity. Again, this is one of the most lethal cardiovascular drug overdoses uh, which you may come across. So when we talk about the classification, the differential effects, so conventionally what we use CCBs belong to three main chemical classes. That is phenylalkylamines, benzodiazepines, and dihydropyridamines. So as we know, verapamil has strong, which belongs to the phenylalkylamines group, has a strong affinity for both myocardium and the vascular smooth muscle, and it suppresses the cardiac contractility as well as the SN nodal automaticity, AV nodal conduction, and causes potent vasodilatation. So when the verapamil is involved, we know we will come across a patient who will have both the effect. It suppresses the contractility, also it's a potent vasodilatation as well. Then benzodiazepines, that is diltiazem, what we come across, has a similar range of effect with verapamil with less vasodilatation. So it is less potent. Its effect is more potent on the chronotropic action. And when we talk about the dihydropyridines, they have very effective vasodilators action and exert less influence on the cardiac pacemakers and myocardial. So it's very important to know which drug is playing a role, because if it's a verapamil, then you will see both the effect on the suppresses the contractility as well as the hypotension. If it's a diltiazem, then we have more potent chronotropic action. If it's a dihydropyridine, you will see more profound hypotension. In fact, you might see the reactive tachycardia in spite of the bradycardia in those cases. So it has also got the unique metabolic effect of the calcium channel blockers like pancreatic and insulin. So calcium channel blockers of all subclasses reduces pancreatic insulin secretion and induces end organ insulin resistance, causes hyperglycemia. And this metabolic effect distinguishes CCB from the beta blocker, as I explained in the earlier when I was talking about the beta blocker as well. And it also has causes mitochondrial dysfunction, which results in the lactate production, ATP hydrolysis, metabolic acidosis, and the impaired myocardial energy metabolism. So when we talk about the clinical presentation, we have the drug cardiovascular signs like hypotension, bradycardia, all marked with a significant ingestion, but we might not see bradycardia, especially when the dihydropyridine solutes like nifedipine and all. There we see more of the profound hypotension. In fact, we might see tachycardia, which is a reaction to the hypotension. Laboratory findings, we will see the hyperglycemia, which is a differentiating factor from the beta blockers, and patient can deteriorate very rapidly. It's very important to aggressively intervene and treat this patient. So diagnostic, we don't do routinely the assay of the calcium channel blockers. So it's very important to get the history of the patient and need to know the clinical presentation exposure, what we are facing with. So unexplained bradycardia might be due to the other reasons like beta blocker toxicity, clonidine toxicity, disc toxicity. We might also deal with the structural cardiac disease, and active myocardial ischemia may present in the similar way. So it's very important to differentiate all those. So initial stabilization, all again is the same: airway and breathing. Secure airway if the mental status deteriorates, which is more commonly seen with the beta blocker than with the CCB. Always try initially IV crystalloid boluses. If there's a bradycardia, give atropine 1 milligram IV for bradycardia, repeat up to the 3 doses. Gastrointestinal decontamination again comes over here in the dose of activated charcoal 1 gram per kilogram, maximum up to 50 gram to all patients who are hemodynamically stable, have come within 1 to 3 hours, have normal mental status, and there are no major contraindications. Whole bowel irrigation, especially for the sustained release drugs, till we have the clear effluent, can be used for the potentially life-threatening ingestion, extended release preparation, or the large ingestion requiring enhanced elimination. So severe CCB poisoning protocol, initial is about the IV calcium salts, what we are talking about. So the rationale behind calcium administration is that increased extracellular concentration will promote calcium influx via unblocked L-type calcium channels. How the responses are variable and suboptimal with severe toxicity. So calcium may improve hypotension and conduction disturbances, but is less effective in the management of bradycardia. The doses what we are using ranges from 4.5 to 95.3 milligrams per liter, and the calcium chloride contains triple the amount of elemental calcium on weight to weight basis over calcium gluconate. But calcium chloride ideally should be administered via central line because of the risk of skin necrosis on extravasation. Initial dose is 10 to 20 ml of 10% calcium chloride with repeated boluses can be repeated every 10 to 20 minutes. Then the second line treatment is about the glucagon, which is secreted from the alpha cells of the pancreatic act through the duct through the activation of adenyl cyclase via G protein. What it does is bypasses calcium channels to improve cardiac functions, and also it improves there's improvement in the heart rate, improvement in the cardiac output, and the reversal of animal AV blocks, what has been seen in the animal model. So again, the dose is 5 to 10 milligram over 1 to 2 minutes, and the effects is seen within 1 to 3 minutes, would usually last for 10 to 15 minutes, and this is why it's very important to use the boluses. High dose insulin therapy, we have discussed, it is to be used in the same way as it was for the beta blockers. We might have to use vasopressors in certain cases, and as discussed, norepinephrine is the drug of choice. But for the inotropic effect, if there's a bradycardia, if there's a negative chronotropic effect, we might consider using dovitamin and dopamine as well. IV methylene blue can be used for the refractory vasodilatory effect, and we can use a lipid emulsion therapy as well, that is intravenous lipid emulsion therapy. The reason being is we all know lipid is an oil in water emulsion that creates a lipid phase within the plasma and pulls a lipid soluble drug into the lipid phase in blood. So what happens is lipid emulsion infusion can sequester intensely lipophilic drugs like verapamil and diltiazem, and thus reduce the volume of distribution. There's also something called as enhanced metabolism therapy that argues that the infusion of lipid emulsion provides a sustained fatty acid energy source to the myocyte under toxic metabolic milieu. So continue IV crystalloids and IV atropine in addition to these therapy. Do not stop it. So the first line therapy would always be the IV crystalloid for the hypotension. Second line, of course, IV atropine for the bradycardia, followed by the IV calcium salt, as we explained, or the presence of extracellular calcium will allow calcium to cross through the L-type voltage gated channels, followed by the IV glucagon. Then maybe we have to use the high dose insulin euglycemia therapy along with the dextrose. Now, in certain cases, we might consider using vasopressors, methylene blue, and maybe the lipid emulsion. Doses I've already discussed about how do we use high dose insulin therapy as it was discussed in the beta blocker. And the rescue therapies could be the methylene and the lipid emulsion, as discussed, used especially in the refractory shock. And the lipid emulsion is used in the bolus of 1.5 ml per kilogram over 1 minute. May give additional 2 bolus if there's no response, but we have to continue with the infusion, and it can maximum go on with the 12.5 ml per kilogram over 24 hours. It needs a very sequential monitoring of the serum triglyceride. It can lead to the severe pancreatitis as well. So the cases refractory, which are not responding, we might consider transvenous cardiac pacing, IBP, that is intra-aortic balloon pump, cardiopulmonary bypass, and also the VA ECMO for the cardiovascular collapse who are not responding despite of the maximal therapy. So when we consider the high dose insulin therapy, can be used in both the cases, that is beta blocker as well as the calcium channel blockers. And we talk of the calcium administration are used in both the cases. Even the glucagon is more effective in the beta blockers overdose, but can also be used in the calcium channel blockers overdose. Same is true with the lipid emulsion therapy, can be used for both the overdoses in the beta blockers as well as the calcium channel blockers. Mechanical support, that is the VA ECMO, when the patient are not responding despite of the adequate therapy, can be used in both the cases. So it's very important to recognize early, to know the timing so that we know the trajectory of the events which we are anticipating, how it's going to affect. And thank you for your grateful, I'm really grateful for attention and time and the kind of love what I'm receiving through this talk. So it's again a request to kindly share, subscribe my YouTube channel, share the talk, spread the knowledge. Thank you very much.